Hello, everybody. How's everyone doing? Welcome to class. If you haven't already, I encourage you all to say hello to the class and tell us a little bit about yourself on Flipgrid on As You Learn. And let me start today by asking if anybody has any questions about syllabus that we went over last class or any of the material that we went over last class. We all good? Okay. Well, we're going to pick back up today and really focus on why study women's health. Let me get my PowerPoint moving here. Okay. If we, as a class in psychology, I want to talk about how important behavior is in determining our health, or how important behavior is in determining if we get sick. And it's 40%. So a lot of our health is a function of our lifestyle behavior, okay? We also find that some of our health is determined by our genetics, okay? And most of us can't pick our parents, and our genetics are our genetics, but there is some science nowadays where they're able to do some genetic manipulations for people who have certain types of conditions. Other factors would be things like, in my profession, my job is very safe. My grandfather, on the other hand, in West Virginia, was a coal miner, and he got sick from coal mining, got black lung, and then got cancer. And so in that situation, that type of environmental other factor would be things like the type of profession you have or where you live. And then 10% of our health status is a function of our medical care and our access to medical care. And so it's relatively small here, definitely smaller than how influential our behavior is. But I do want to emphasize that in our United States, there are the haves and the have-nots when it comes to healthcare. I've got nice healthcare insurance. I know when my kids were younger, if my son rolled his ankle on the soccer field, I would make him an appointment and go get his foot x-rayed, as an example, and not necessarily have to fret that I couldn't buy groceries that week because I had to take my kid to the doctor. But there are a lot of people out there that really do not have access to healthcare. They're not well insured, or they're underinsured. They do not have the luxury of access to healthcare. So lots of politics behind some of those disparities there. Okay, now I want to talk a little bit about how powerful lifestyle is in determining our health. I'm going to move my little pictures of you guys over here. Okay. This is the nurses' health exam study, and it's a prospective study where they've taken a bunch of nurses and they enrolled them in the study, and then periodically they would reassess them and retest them. If any of you all out there have the bandwidth and you've got your camera turned off, if you would please turn your camera on so I can be looking at faces instead of looking at just names. That would be really helpful for me. So tracking nurses into the future. In this particular study, these were all women nurses. I know guys can be nurses too, but in this study, it was all female nurses. And remember, we talked about the other day that coronary heart disease is the leading cause of death for both men and women. And so in this study, the women who followed, the nurses who were female, who followed a healthy lifestyle, decreased their risk of coronary heart disease, number one cause of death, by 82%. That's huge, okay? And these were the women nurses who avoided smoking cigarettes, exercised at least a half an hour a day, avoided having a BMI, a body mass index, or body size that would be considered to be overweight. They ate healthfully. If they consumed alcohol, they did so in moderation. These healthy women decreased their risk of coronary heart disease by 82%, which means lifestyle makes a difference. Okay, if everybody out there was following this healthy lifestyle, we would have a lot less coronary heart disease. Okay, but there's a punchline here. For those of you who've had my health psych class, you know what the punchline is. But can anybody guess and just yell out for me what percentage of nurses you feel like followed this healthy lifestyle? Somebody give me a percent, an estimate.
15.
Okay, we got a 15. Anybody else want to take a guess?
I'm going to go with a 30.
30, okay, a little bit higher. Okay, here's the punchline. Now, these are nurses, so you would hope that these individuals follow a healthy lifestyle. But in the nurses' health exam study, only 1% of nurses followed all of those healthy lifestyle behaviors. Okay, which means there's plenty of room in our culture to try to help women become healthier by engaging in all those healthy lifestyle behaviors. Okay, what this also suggests, and some of you in here are pre-professional, pre-healthcare, healthcare providers who they themselves follow a healthy lifestyle are a lot more likely to counsel their patients in healthy lifestyle change. Healthcare providers who do not follow a healthy lifestyle are a lot less likely to counsel their patients in healthy lifestyle behavior change. And you all know the social cognition phenomenon of that is just, it's hypocrisy or cognitive dissonance. Okay. If I'm a cigarette smoker, I am not going to be counseling you in smoking cessation. Okay. Because that would make me a hypocrite. So if we can get healthcare providers healthier, that's going to have a domino effect out into our healthcare system and the patients that they care for. Okay. Okay. So why study women's health in particular? And there are a lot of reasons here. So we're going to go one by one through each of them. So there is some known discrimination in the healthcare system. So as an example, remember coronary heart disease, #1 cause of death for women and for men in our culture. But we know by studies that first responders like EMTs, and we also know emergency room physicians, when women are having a heart attack and they call an ambulance, they go to emergency room, the EMTs and the ER medical doctors are a lot less likely to diagnose it as a heart attack in a woman compared to the exact same symptoms in a man. Okay. And that's problematic because some of those women fall through the cracks. They get dismissed from the ER. Oftentimes they think they're having anxiety or they're having panic or they're somatizing type of thing. And so that's a problem. And we're going to see a little bit later, that's getting a little bit better, but it's still problematic. Medical treatments that are based on male models or males only in research. Historically, scientists, when they were testing out a new drug or a new treatment, did not like including women in their participant pool because their menstrual cycle was considered to be a nuisance. Okay. And they would have to control for it, whereas they did not have to do that when they had male participants in their study. Okay. But that kind of begs the question, if the treatments and drugs were tested on men only, then that left us with, hey, does this work? Is it effective for women? Do women have different kinds of side effects than men? If we don't study these things on women, we're not going to know how they work or don't work or side effects or safety for women. Nowadays, National Institute of Health that funds a lot of healthcare research, you absolutely have to include men and women in your study, as well as you have to include different races of individuals in your study, so that we know if a new treatment or a new drug is safe and effective for everybody. Okay. And again, nowadays we think about, menstrual cycles are a reality for women. So don't we want to know? As an example, some medications are more effective at different times in the menstrual cycle for women. Okay. So National Institute of Health, you can no longer exclude women in research. Another example would be procedures. When they go to do what's called an angioplasty, when you've got clogged arteries, they send up in through the groin, up into the heart and inject dye and find out where that clogged artery is. And women were having, when they had that procedure, they were having more problems with that procedure than they were for men. And the reason was simply because women's arteries are smaller than men, they had to adjust the device. Okay. You would not want to send up a device inside of women's tiny arteries that is meant to fit men. Okay. I think about this kind of thing a lot of times when I'm about 5'3". When we sit in chairs, if you're a smaller person and you sit in chairs and it's not comfortable, it's because that chair has been sized to fit men, as an example. Okay. Questions here? Okay. Biological differences related to reproduction for why we want to study women's health. Certainly looking at things like what are menstrual normalities, what are menstrual disorders for some women. Diseases that affect the breasts, the uterus, the ovaries, the organs that are unique to women, which would be uterus and ovaries. Men do get breast cancer, but women get breast cancer much more frequently than men do. And then sexually transmitted infections. And there's some biology to this. Heterosexual individuals, women are more likely to receive a sexually transmitted disease than they are to give and transmit an STI to a partner, a sexual partner. And the reason for that is men's genitalia is on the outside and it stays relatively dry. Women's genitalia, you think about vulva, vagina, is very warm and moist. It is a nice environment for pathogens coming from a sexually transmitted disease. It's a nice place for that stuff to live and reproduce. Okay. So again, women more likely to contract an STI than they are to spread it. Issues of just controlling reproduction. I have 2 grown sons. I am so pleased that I had 2 grown sons. I am also very pleased that I was able to control reproduction, because otherwise I would probably have 20 grown sons and a baby and daughters and whatnot. And there's no way I could have had the same quality of life if I was not able to control reproduction. Okay. The medicalization of childbirth. I've been watching Call the Midwives on Netflix. It's a really enjoyable show to watch because they bring up all kinds of different women's issues. In the United States, we perform way more C-section births than the World Health Organization recommends. So about 30% of our births end up going from that attempt at vaginal birth to a C-section. WHO recommends that it's less than 5%. So we are likely performing more C-sections than are necessary. And the reason for that, and this makes a lot of sense, if I were an OBGYN, I would probably be performing quite a few C-sections, because if there's ever any evidence that that baby is in distress, they get that baby out of there immediately with a C-section, instead of waiting for that woman to be able to birth a baby who is known to be in distress. And so that's been driven by lawsuits. Okay. And OBGYNs as physicians have the highest malpractice insurance compared to other physicians. And it's because of those lawsuits. Questions there? Another reason to study women's health is the medicalization of menopause. And I'm in a generation that's very different than my mother's generation, my grandmother's generation. Back in those generations, when women approached menopause and they started having any kinds of symptoms, and some of the earliest symptoms of menopause are having hot flashes, vaginal dryness, oftentimes weight gain in the midsection, things like that. Back in the day, as soon as women had any symptoms and they complained about any symptoms, doctors put them on hormone replacement therapy, that's the HRT, right away. And the hormone replacement therapy took away the menopausal symptoms. Thank goodness, though, there were scientists that were studying the use of this hormone replacement therapy, because what they were finding, and we saw a spike in coronary heart disease in women 50 and over who were on these meds. We even saw a spike in breast cancer development, and we saw a spike in pulmonary embolisms, which is a blood clot in the lungs. Thank goodness we were studying this scientifically, because what was common clinical practice, once we researched it, we found out it was harmful to women. Okay. Nowadays, it'll be interesting to see for many of you women when you reach that age and what your generation is like. Nowadays, in my generation, doctors are not putting people on hormone replacement therapy unless they are absolutely miserable. And then they're putting them on very, very low doses of hormone replacement therapy. And then they're trying to wean them off of it as soon as possible. Another thing that they're doing nowadays for women who are really struggling is giving plants that have phytoestrogens, plant-based supplements, instead of the traditional hormone replacement therapy was from, they would take, it's called Premarin, mare meaning horse, they actually would make the Premarin from pregnant horses' urine. Okay, that's where they would get the natural hormone replacement therapy. Other issues associated with this would be performing unnecessary hysterectomies, where they remove women's uterus and remove their ovaries. So we're trying not to medicalize childbirth as much. We're trying not to medicalize menopause as much. All of these things being natural things that happen to women. Any questions here? Okay. There are some brain functioning differences in men and women. Physically, women are slower to build muscle mass, and it's harder for women to lose weight compared to men, but we have less muscle mass. And even if we are doing resistance or weight training, it takes us longer to build up muscle mass compared to men. And that makes a lot of sense, because for men, testosterone tends to build muscle mass. We women, we do have testosterone, but we have much lower levels of testosterone than men do. Issues related to mental health. In US culture, we do a lot of reliance on medications for mental health issues. And about 23% of women ages 40 to 59 have been prescribed antidepressant medications. So if they're complaining about depression, they're complaining about anxiety, they're complaining about stress, the go-to tends to be putting them on a medication as opposed to referring them to counseling or referring them to psychotherapy. And they're some of the most commonly used medications in adult women. Lack of using psychotherapy, social work, counseling. Only 50% of people who've been prescribed antidepressants have been seen by a mental health professional. So somebody who can do the counseling or the psychotherapy. Okay, so lots of medicalization of mental health going on in our culture also. Then there are all these socio-political issues associated with women's health. And we're going to cover some of this stuff a little more throughout the semester, but women more likely to be victims of domestic violence. And we've actually seen domestic violence rates go up during the pandemic when people are trapped at home. Parenting, women are a lot more likely to be single parents than men. And even in couples where there are children, the women are a lot more likely to do more housework and do more childcare. Issues of women being victims of rape and victims of sexual assault. Women, in terms of socioeconomic status, and keep in mind, socioeconomic status is a function of income and education level, but women are twice as likely compared to men to be below the poverty level and to be struggling financially. And then when it comes to health insurance, oftentimes women have to pay more for health insurance than men do. They are a lot less likely to be covered by health insurance, and that's especially true for minority women compared to men. 52% of women are uninsured or underinsured, and they are twice as likely to be dependent on a spouse's healthcare insurance. And then all of these issues that we're talking about here with health insurance coverage have actually worsened during the pandemic because so many women have left the workforce to stay at home, particularly if they're caretaking for children and children are at home doing online school during the pandemic. We're going to talk about issues with the pandemic here in a bit. So any questions about these socio-political issues? Okay. Women tend to report more experience of stress than men. Women have more active immune systems. And actually, we think the biological and the evolutionary explanation for that is pregnancy and keeping our body infection-free for pregnancy for the female body. But because of that, more women have autoimmune diseases where our very healthy active immune system gets out of kilter and starts attacking itself. So I have a friend that has lupus as an example, and that's an autoimmune disease where her own immune system is overactive and it tends to attack its own connective tissue in the body. So women more likely to have autoimmune diseases. Women are more likely to be caregivers, caregiving the sick, caregiving to children, caregiving to parents. And so balancing that work and home life for women. Concerns for elderly women. Women tend to live longer than men. And so there are more women who have been widowed, who've lost a partner to death, and more likely to be living alone for longer than men are. Women tend to have more disabilities than men. And again, that's problematic if they are not insured or they're underinsured. And then more financial issues for women, lower pension, meaning lower retirement funds. If they have not been in the workforce as long, if they have not made as much money in the workforce for a long period of time, they're going to have less pension, less retirement to live off of beyond retirement. The poverty we've talked about, and then women, more issues with being prescribed medications that are not covered by Medicare. And Medicare is the insurance, the federally funded insurance that kicks in for people 65 and older. Okay, so we've got some special issues for older women here. Any questions or comments? Okay. We have made some gains, and all of this is pre-pandemic, but I do want to talk about some of the really cool gains that women have made in healthcare prior to the pandemic. So back in 1972, you all were probably eggs back then, Title IX was passed. And it simply, Title IX is no person in the U.S. shall on the basis of sex be excluded from participation in, be denied the benefits of, or subjected to discrimination under any education program or activity receiving federal assistance. So as an example, part of the reason why, let me go back. Part of the reason why we have women's sports have to be funded with scholarships equivalent to male sports that are funded through scholarships. That would be an example of a Title IX mandate. There are also, there are fundings for universities for women's health care and assisting with women being able to get female gynecological care, but then also being able to get birth control if women, making sure that they're able to get birth control so that they can succeed in college. That would be some Title IX types of mandates. In medical school back in 1982, 31% of med students were women, but by 2019, they tipped it. They tipped it over to 50.5%. Go Grey's Anatomy. So some big strides in medicine. Pharmacy degrees, back in the 80s, only 40.5% of pharmacy degrees were awarded to women, and that was up to 62% by 2013. In psychology, we're interesting in the field of psychology because women have tipped a long time ago in terms of doctoral degrees. So 76% of doctoral degrees in psychology were awarded to women. We know amongst our psych majors that men majors are somewhere between 20 and 30%. And then the women are somewhere, it fluctuates a bit, but 70 to 80% of our majors are women in psychology. And then the last one, dental school. Only 16% of women in the 70s were in dental school. By 2014, it was up to 48%. Okay. So one way of thinking about it is, my bet is many of you women in this class, when you go for healthcare, particularly if you go for gynecological care, nowadays, a lot of women prefer to see a woman. Okay. In my parents' generation, there weren't very many women doctors to see. And there was a bias early on when women moved into the healthcare field. Even women oftentimes would want to see a male doctor because they thought, they were assuming the male doctor was smart and knew what he was doing, and the female doctors might not. So we've had this really interesting generational change that has occurred. But because of that, there are more women out there to see in healthcare. Okay. My sons were after they moved from a pediatric practice, they moved into my primary care practice, and they were seen by a woman nurse practitioner. And I was pleased about that. It's like, good, they've got this role model for medical care. That's a woman. Questions here about gains that we had made in healthcare. Okay, this is where it gets gloomy. So since the pandemic, we've had some very interesting kinds of issues for women that are affecting women more so. More domestic violence and more interpersonal violence. And again, for individuals, particularly if they're on lockdown and they're trapped at home. There has been more stress for a lot of individuals during the pandemic, and oftentimes stress is a precursor to partners being violent and engaging in domestic violence. 70% of our healthcare workforce is women, and so there are a lot more women on frontline risk. So more nurses, more medical doctors, more women at risk for contracting the virus because they're on the front lines. Somewhere between 4 to 8 times more women compared to men have had to drop from the workforce for childcare during the pandemic. I know I've got some friends that have small children, and they talk about they're trying to work online. They're trying to supervise their children at school online. There's more house care that needs to be done because everybody's at home all of the time. There's more cooking that has to be done because everybody's home all the time. And it just makes me count my blessings. I very much enjoyed raising my sons, but I am so glad they are not small and under my feet during a pandemic. Life would have been very, very different in those circumstances. I feel for these individuals. Women of color are most affected in needing to drop from the workforce and caretake. And single moms, that is a rough place to be in life during a pandemic. All by yourself, caretaking for children, trying to work online if you've got the luxury of working online. And a lot of individuals have had to just completely drop from working. Because of that, there's estimated, and I can't even conceptualize what 64 billion looks like, but this is the data I found, about 64 billion in lost income by women because of the pandemic. About 1 in 8 are experiencing food insecurity. And somewhere in ranging between 29 and 43% could face eviction from households. I do know the new federal administration is looking into laws trying to keep people from getting kicked out of their homes right now. When people can't pay their rent, they can't pay their mortgage. The last thing we need is more people homeless during a pandemic. Loss of health insurance attached to full-time employment. I know my health insurance is attached to my employment, and for most people it is. It's the minority of individuals who buy the exchanges where it's independent from their employment. Loss of the retirement security, like that pension we talked about in the previous slide. And because less women are in the workforce now, there's actually going to be a reduction in our local, our state, and our federal tax base. Because if there's less taxes being taken out of income, then we're going to have less in our tax base. There are threats to workforce advancement and promotion. If women drop from the workforce, it's hard for them to get back in the workforce at the same level of employment that they were in. And then if women are being torn and having to childcare and work, they're less likely to be working towards promotions and moving up the ladder and making more and more money. I know there have been concerns, just as an example, I've been tenured for a long period of time, meaning I've got really nice job security. It takes 6 years to get tenure. You've got to prove that you can teach. You got to prove that you can do research, certain amount of service that we have to do. And then it's our own faculty that vote us in or vote us down for tenure. There's been a lot of concern though for assistant professors. And again, assistant professors who are not yet tenured. I worry a bit that the female assistant professors, particularly if they're caretaking children in their home right now, they're going to have a much harder time meeting the requirements for tenure. And so I worry about women in academics that way. And you all probably know, like we talked about the psych majors, that the majority of psych majors are women compared to men. But we women in at least the psychology department, we're a huge department. We have about 45 PhD tenure track or tenured professors, but we women only make up a third of the psychology faculty. So 2/3 of the PhDs are men, whereas it flips with the majors. We've got a lot more undergraduate women who are majors. So there's concern that this pandemic could undo about 25 years of progress that women saw pre-COVID-19. And you've seen it on the news. We had a wonderful surge in Black Lives Matter and activism happening starting this past summer, although these issues of sexism and racism have been going on for a long period of time, but they've been exacerbated during the pandemic. All of this is getting worse for people. So it'll be interesting to see how the new administration handles this. Questions about this? I know this is anxiety producing, seeing some of this. Anybody? Here are some recommended laws and policy that it'll be interesting to see what happens in the new federal administration. There is a proposal that childcare is essential. Women are a lot more likely to be able to work in the workforce, get promoted, et cetera, if they've got quality childcare. And as of right now, there are some children that qualify for Head Start. In certain counties that have Head Start, if children are below the poverty level, they are given free childcare. But there is no statewide and federally funded preschool childcare. That would give women so much more freedom if we had something like that. Okay. It's been a long time since my little guys were in preschool, but it was expensive. It was expensive to have quality childcare for them. Having laws where we would all have paid family and medical leave. So for women to get paid when they went on maternity leave and had a baby, for women to be allowed to be paid if they were caretaking somebody who was sick, gives women, and also not only just getting paid during leave, but laws that protect an ability to return to that position when they go back into the workforce. Because in a lot of situations, employers, when women would take leave, would not hire them back unless legally they had to hire them back. Okay. And historically, this has been law for a long period of time. A lot of employers did not like to hire women because they were concerned that they wouldn't be as dedicated to their work if they had children. And a lot of employers didn't like to hire women because they didn't want to have to compensate and hire somebody when a woman left for maternity leave. Now, based on federal law, both men and women are allowed family leave. Okay, but it's only X amount of time. It's usually 6 weeks of leave. At the university, we're very liberal at the university, and I've known quite a few women. We didn't have maternity leave when my guys were born, but things have changed very rapidly since that period of time. Both male professors and female professors are allowed family leave when they have a baby or they adopt. And then one of my male colleagues, as an example, he took family leave last spring to caretake for a sick parent. Okay, so being able to just guarantee that it's paid and then having leave that is longer. In a lot of socialized countries, individuals are allowed up to a whole year of paid leave when they have or adopt a child. In the US, it's only 6 weeks for most companies. Okay. Okay. And then the laws about rehiring. So any questions about this kind of stuff? These are the kinds of things where it would be possible to create laws and policies that could narrow some of these disparities and some of these issues that women face more than men. Okay, this is some good news. And I actually found a research study that had this data because I'd been hearing a little bit about this, just kind of like surfing around on Facebook, that type of thing. But countries led by women compared to countries led by men. And so we've got some pictures here. We've got countries, Germany, New Zealand, Finland, Taiwan, that have women leaders. And then I found a research study that was published this past year, where they actually looked at data in these countries led by women versus led by men. And I want you all to critique this here in a second. There were less deaths per capita, so per X amount of people, in the countries led by women compared to men for COVID-19. These countries did a better job of flattening the curve, meaning keeping the healthcare system from toppling over its capacity. And there were lower peaks in daily deaths in these countries led by women compared to these countries led by men. And then some of the reasons why, we're going to pat these women on the back here, but then I want you all to critique this. I want you all to be thinking critically, what's something else that could be going on here? Women seem to be, when they're trying to answer why this difference existed, honor diverse perspectives. So women more likely to surround themselves with people and advisors that may be different than them. Women more likely to rely on science. And you all know, we talked about this the other day, the United States during this pandemic up until today has not done a very good job of following the scientific evidence. Okay. Less concern for women about appearing weak. And you all have seen, there've been some males featured in the news that didn't want to be seen with a mask on because they felt like wearing a mask made them look weak. Okay. I have no problem wearing a mask. I don't care about looking whatever, that type of thing. And these women do a better job of eliciting cooperation from the public. So getting people to comply with safety protocols, they seem like they've been better at that. Okay, so we can attribute some of this to these women having a different way of leading, but tell me what else could be going on here. I want a critique. Sophie, I can see your mouth moving, but I can't hear you.
It's not doing it.
Oh, there you are. There you are. Okay.
Okay, we're good. Okay. I was just saying, I don't know about other countries, but I know in the US it has been very like politicized, the whole like mask wearing and everything. And us being in an election year, I feel like it'd be very different if we had not been in an election year compared to maybe some of these other countries. So
yeah,
that's one idea about it.
It has blown my mind during this pandemic how mask wearing has been associated with being a Democrat, and lack of mask wearing has been associated with being Republican in one's values. It's bizarre to me that a health procedure could be associated with that. And then that whole idea of my lack of freedom, like you're taking away my freedom if you're making me wear a mask. And my analogy for that one is a stoplight. Like, how dare you turn the light red and keep me from going? It is my right to go through that intersection, And it's one of those things where, stoplights really work well if people obey them, right? It's one of those it's been bizarre to me how this has been politicized. Okay. Other critique. These are countries led by women that have fared better than countries led by men during the pandemic. What else might be going on?
I am not sure about this, but could it have anything to do with the healthcare being universal or socialized?
That's part of it, you bet. Yeah, socialized healthcare. And with socialized healthcare, when everybody has access to healthcare, you're going to likely see better healthcare, particularly in a pandemic. Keep going.
One thing that stands out for me is that even though it says per capita, each of these women are ruling smaller countries than like some of the other countries that are probably in the study.
Yeah.
And it's also a smaller sample size of women versus men.
Yes. Yes. But with the smaller sample size, to be able to have had the statistical power to find these results, that actually means that these effect sizes were pretty big, if that makes some sense. If you've got small in size, but you've got significance, you've got pretty large effect sizes. The last thing I just want to point out is that could it be, well, you've got the socialized medicine, but could it be that countries that have elected a woman to be their leader are different culturally than countries that have never elected a woman to be a leader? And then I think about, again, going back to the mask wearing, the Democrats more likely to be fine with the mask, the Republicans less likely to be fine with the mask, that type of thing. So it could be that you've got people with different mindsets in these countries here. Okay. All right, real quick definition of health by the World Health Organization: state of complete physical, mental, social well-being, and not merely the absence of disease or infirmity. So health doesn't just mean that we're not sick. Health means that we're striving for total well-being. Okay. Want to give you some definitions here of, because we're going to be talking about integrative medicine all throughout the semester. Integrative medicine. So let's talk about traditional medicine in the US healthcare system. Our traditional medicine has been biomedical medicine. So go to doctor, get diagnosis, get a medication, or get a procedure or a surgery to fix whatever ails us. That's traditional medicine. Integrative medicine is when we're combining those traditional medical therapies with these complementary and alternative medical therapies where there's scientific evidence and there is safety and effectiveness. Okay. And mental health professionals, when we're offering integrative medicine, we oftentimes call this behavioral medicine. That the behavior change that comes from the counseling that we do is the medicine. So this could be, as an example, it could be teaching somebody to do meditation to control high blood pressure, as opposed to giving them a medication to control high blood pressure. Okay, that would be an example of integrative medicine or behavioral medicine. Complementary and alternative medicine, or CAM, are those things that aren't considered to be the traditional medicine. So again, that example I just gave you, meditation for blood pressure would be a CAM therapy. Public health, defined as the branch of medicine for public health, and it includes hygiene and sanitation, cleanliness. Epidemiology, which would be the scientists that collect the data. And public health is usually focused on disease prevention and disease management. So as an example, our local public health department is doing contact tracing, and our local health department, if you were to get sick from the coronavirus, is offering case management, where they've got a nurse that contacts a person on a regular basis, make sure that they have what they need at home, make sure that they have a thermometer, maybe a pulse ox device, making sure that they're getting prescribed medication, that type of thing. And then they're contact tracing. So they are, if that infected person was exposed to other individuals, they're calling those other individuals and say, you have been exposed, you should probably quarantine for 14 days and go get tested for COVID-19. Okay. Public health is tax-based funded, and somebody mentioned in the last slide socialized medicine. In our country, we have socialized public health, but we do not have socialized health care insurance. So healthcare insurance would be private insurance, like my plan is Blue Cross Blue Shield, there's Cigna, there's all kinds of other different plans out there. The public funded healthcare insurance would be Medicare, like we mentioned, for people 65 and older, or people with a registered disability. Most Medicare funds come from federal taxes, federal government. Medicaid, on the other hand, tends to be state funded for individuals that fall below the poverty line. And the poverty line is defined differently by states. So the poverty line as defined in North Carolina could be different than the way they define it in, say, Tennessee, as an example. But Medicaid is for individuals who are quite poor. And in the United States, because our health insurance has been privatized and our public health has been socialized, there wasn't very good cooperation between the two. Okay. The only thing that I have seen that I feel like has been good cooperation, a lot of insurance companies have been offering COVID testing for free. A lot of insurance companies have, if people needed emergency care, have lowered their copay for things like that during the pandemic. So the insurance companies have been trying to do good in the United States, but they haven't automatically been linked to public health. In those countries led by women, they have been historically linked. They've already been cooperating, if that makes sense. And so I think some of the reason why those female-led countries have fared better during the pandemic is because of that. Okay, that natural cooperation between the healthcare providers, public health, et cetera. Questions here on any of these definitions? Okay. Few more definitions. Some of these, you guys, you're going to know these definitions already, but we're going to just throw them out there so that we're all on the same page. Science, study and investigation of nature through observation, reasoning aimed at finding the truth. Evidence-based medicine, or sometimes called clinical practice, is an approach to healthcare practice in which the clinician is aware of the evidence that bears on his clinical practice and the strength of that evidence. And so healthcare providers borrowing from science and then applying it to their patients or their clients. And then evidence-based clinical practice is an approach in decision-making in which a clinician uses the best evidence available in consultation with the patient to decide on the option that suits the patient best. So it'd be laying out scientifically known options for patients and then empowering them in their own healthcare to assist them in making the decisions on what kind of treatment they want to pursue. Any questions about any of these definitions? Many of you all already knew this stuff, but just going over it just in case. Okay. We've already kind of defined behavioral medicine, but in behavioral medicine, we're applying psychology or another allied health profession. So we could be applying, say, nutrition, physical therapy, occupational therapy, combining that with traditional medicine to treat people who are medically ill. Okay. And I'll use that example of meditation for high blood pressure, or we could be using exercise therapy to help somebody lower their glucose levels when they're pre-diabetic. Those would be examples of behavioral medicine. So instead of automatically giving them medications, helping them with lifestyle change to try to prevent disease or treat their disease. And then health psychology is the use of psychology for prevention and community-based interventions. So health psychology is more prevention focused. We're trying to prevent mental illness, prevent medical illness. Behavioral medicine is more treating those things. Any questions about those two definitions? Okay. All right, I told you we were going to define epidemiology here. We have certainly, epidemiology is kind of mainstream word nowadays during the pandemic. And I think we're going to be hearing more in the news about what epidemiologists know about. I think we're going to be hearing more science in the news in the new administration. But let's talk about Semmelweis and childbirth fever. So Semmelweis was the head of a hospital in Vienna back in history, at a time in history where instead of like the show called The Midwives, where the midwives would come to the home and everybody would have home births, there was a zeitgeist or a trend at this point in time in history where it was considered to be a safer thing to go to the hospital to birth your baby as opposed to having a home birth. Okay, so it was this trend. So hospitals were trying to figure out the best ways of accommodating women in labor and delivery at that time. Okay, in this particular hospital, Semmelweis Hospital, he had a problem. There were a lot of women that were coming to the hospital to birth their babies. After the birth of their babies, they would spike a fever, complain of horrific abdominal pain, and they were dying. He had all these moms who were dying after they delivered their baby. Babies were fine, moms were dying. We got a big problem here, okay? Now, there were two types of individuals that delivered the babies. And I've always found that term delivering a baby to be kind of funny in and of itself, because let's give credit to who's really doing the work. It's the woman who's doing the work in that baby, but somebody's got to catch the baby, cut the umbilical cord, all that kind of stuff, make sure the placenta comes out. Two types of people that were delivering babies: med students and midwives. The med students all happen to be men. The midwives all happen to be women. And let's say we got 55 deaths a year from childbirth fever, moms who delivered with the med student, and we got 99 deaths per year, midwives who delivered the baby. Who would you want to see? Who would you want delivering your baby? Somebody shout it out. If you've had my health psych class, you know the punchline on this one. According to this, it looks like I would want a med student delivering my baby compared to a midwife. But there's some very important information that we are missing here. Anybody want to guess what we're missing?
The number of midwives delivering babies versus the number of medical students delivering babies, I would guess.
That sounds like Ash. I can't see you, but I can hear you.
Yes, this is Ash.
All right. Yes, you got it. We need to know the rate. Okay. And so this is more like, I've made this data up, but this is more like what Semmelweis, once he started looking at the data and he was calculating rates, what he found was if that 33 out of 100, 55% of these women are dying with the med students and less than 1% are dying with the midwives. And keep in mind, the truth was in his hospital, there were less deliveries from the med students than there were deliveries from the midwives. Okay. But when he started looking at this data, it's kind of like you can't compare fractions until you get a compound denominator, and then you can compare. Once he started looking at these rates, he was like, whoa, there are a lot more moms dying from med student deliveries than midwives deliveries. So then what he did is he went and he observed their deliveries. And he really saw no difference in how the med students treated these women, how the midwives treated these women. There wasn't anything particularly different going on in the delivery room between these two types of healthcare providers. But then, because he had this data, he's like, there's something going on here. And he was trying to figure it out. But then he realized the difference was what they did in between deliveries. Okay. The midwives hung out and baked and made tea and they knitted and they gossiped and they hung out together in between deliveries. The med students, on the other hand, were either in their books reading and studying, or the med students were down in the cadaver lab dissecting rotting cadavers, dead people, dissecting, learning their anatomy and physiology by dissecting dead bodies. We're on to something, aren't we? What are we on to? What was going on here? Do you think the difference in what they did?
They were infecting the women after working on the cadavers.
Thank you, Sarah. Yes. And we didn't have the microscope didn't exist back at this point in time. Okay. So it wasn't like you could take samples and look under a microscope and see the pathogen. But knowing what we know now today, yeah, they're in these rotting cadavers. They're dissecting the cadavers, and then they're going and having exchange with mom's blood when they're delivering babies, and then moms are getting infected from these rotten cadavers. It wasn't until Semmelweis had an aha moment there was a male professor in the cadaver lab and a male med student, and the male med student accidentally sliced the professor's finger. And we had our first case of childbirth fever in a man. That professor who got cut spiked a fever, complained of horrific abdominal pain without having delivered a baby, obviously, and he died. Okay. And that's where Semmelweis is like, aha. He asked all of his healthcare providers to start washing their hands in a particular type of solution to clean their hands more thoroughly. And he saw death from childbirth fever drop. Semmelweis tried to publish this information. And it was interesting that people didn't understand germs. There was no microscope back then. He was fired from his job. They would not publish his scientific work. But he is known to be the founder of the field of epidemiology. Okay, so his career was ruined by his great scientific discovery. And nowadays, of course, not only do healthcare providers wash their hands, but they glove and they mask and they do all kinds of things to prevent spread of germs from patient to patient. Okay. So in the science of epidemiology, we've got to control for a time period. You can't make comparisons and have different time periods for different individuals. We need to know we need a representative sample of the population who's on the denominator. So as an example, if we were looking at cases of ovarian cancer and we're looking at the number on the numerator relative to the denominator, we would not include men in the denominator. Men do not have ovaries. Their equivalent are their testes and their testicles. Okay. So if we were doing ovarian cancer, we would only have women as being potentially vulnerable in the denominator. Does that make some sense? If we were looking at testicular cancer, we would only look at men in the denominator. We have to use rates. Raw numbers are misleading. Okay. I get so frustrated, and every now and then I'll hear a reporter report some study about raw numbers. And it's like you can't do that. You know, it's not good science using raw numbers. You've got to look at the rates. Okay. Okay. So defining this, epi meaning upon, demi meaning people, and ology the study of. So epidemiology is the study of that which befalls people. And the assumptions here, which are truthful, that these things, so we could be talking about mental illness, we could be talking about medical illness, we could be talking about injury. Nowadays, we would be talking about infection from COVID-19. We could be talking about death from complications from coronavirus infection. That which befalls people does not befall them randomly, that there are patterns. And it's the epidemiologists that help us understand these patterns and solve these puzzles. Okay. Questions here. I want you all to know this because there has been a lot in the news. Epidemiologists are giving us very good scientific information about the pandemic, but I also want you to have an appreciation for how epidemiologists and their science has given us the evidence, given us the knowledge to practice in healthcare, to practice in public health in ways that are using this math in the best possible way to have the science translate into application and fall into actual practice to help people. Any questions here? Okay. In the healthcare field, there are quite a few different types of research designs, and let's talk a little bit about each of these, and then I'll give you an example of a couple of studies that we've done. Prospective, it would be like that nurses study where you take a representative group of people at time one, you enroll them in the study, and then you track them into the future and measure different things, and then you learn things about them. So from that nurses study, as an example, where we tracked women into the future, we learned that women with these nurses with a healthy lifestyle had a lot less cardiovascular disease than the women with an unhealthy lifestyle. Okay, so that's where we got that information. Another prospective study we've already talked about was looking at hormone replacement therapy in women. In that case, they enrolled women at menopause. Many of the women were given hormone replacement therapy, randomly assigned that, and then other women were randomly assigned to get a placebo and not get real true active hormone. And they tracked those women into the future. And that's where they realized, hey, hormone replacement therapy is causing breast cancer, heart disease, pulmonary embolism. And because of that science, doctors stopped prescribing it on a regular basis for women in menopause. Okay. So I just want you all to have a few samples of these types of studies so that you can appreciate the knowledge that has been gleaned from this science. Okay. A retrospective study would be where you take people at a given time where half of them already have illness, and then you find yourself a control group that doesn't have illness, but they've got to be comparable. The control group has to be, you've got to be matching in age, you've got to be matching in gender, matching in race, matching on any kind of variable that could be important, so that you've got an experimental group and you've got a comparable control group. And then the retrospective is you look backwards in time. However you might do that. So you might look backwards in time and have people self-report their food habits, or have them look back in time and self-report their exercise habits and that kind of thing. And we get information, we get important information from the retrospective. The experimental clinical trial, let me see, I'm going to stop share here, and I'm going to draw randomized controlled trial. So you start with a population and then you randomly assign people, and there's all kinds of different ways you can randomize and do this. But let's say we've got here, this is our control group. Let's say we've got, I'm going to give a medication example. Let's say we're treating people for some kind of medical illness, and this group gets 1 milligram. This group gets 2 milligrams. This group in the control group is the placebo. I've randomly assigned them. And then let's say they go into the clinic every week with their bottle of medication, and they're given meds that all look exactly the same. So they don't know if they're getting a placebo. They don't know if they're getting a 1 milligram. They don't know if they're getting a 2 milligram. The research assistant that hands them their pills is going to be blinded to their condition, meaning the research assistant doesn't know if that person's in control, 1 milligram, 2 milligram. And why is it important that the research assistant is blinded? Anybody?
I don't know if you can see the chat, but Vivian had put, she said to prevent bias.
Thank you. Yes, I cannot, I've got PowerPoint, I've got your pictures, I'm drawing right. I will not have the mental capacity to look at chat. But thank you. Thank you for letting me know that. Yeah, bias. What you don't want is this, nice, kind research assistant, handing out a placebo and going, you can take it, but I don't know if it's going to do you any good. Or handing out the 2 milligram, assuming 2 milligram is better. We don't know that yet. We haven't done the scientific study. Handing out the 2 milligram going, oh, you got lucky. You got the good stuff here. Yeah, they've got to be blinded so that they're not biasing in any way. Now, of course, the scientists that are running the study, they can't be blinded because they've got to know who's in the control group, who's in 1, who's in the 2. So let's say these pills that all look exactly alike, they may have a number on it, and that number means nothing to anybody, but the number tells them if they're in the control, they're in group 1 or they're in group 2. So you've got random assignment up here. You've got double blind, meaning the actual participants are blinded. They don't know what condition they're in. And then the research assistants who are serving whatever the treatment is, they are blinded. So that's the double blind. Now, there's another really interesting thing that is happening here where the researchers should be measuring their adherence to the study. And one way they do that with pill studies, I'll just give you an example of that. With a pill study, the cap may have a little chip in it. And every time you open that pill bottle, that chip notes they've taken a pill. And the assumption is if you take the cap off, you take the pill, right? Now, some people put their pills in these other little kinds of things, but they would say, keep your pills in this bottle. And if you're supposed to take it once a day, then they bring them in. Let's say they've been in the study for a month. They read the chip and see if they've taken that cap off 30 times in that month. You got it? Another way, if we had somebody doing a study where they are supposed to be exercising, we might have them wear some kind of Fitbit or Apple Watch or some kind of device, and we are tracking with their device, are they really getting out there and exercising as much as they've been asked to exercise? Does that make some sense? So you would verify their adherence or compliance to the study. Now we get this really interesting effect though. So let's say in the control group, we've got, 90% of people that did exactly what they were supposed to do. And we've got 10% of the people that did not do what they were supposed to do. We get this really interesting phenomenon. Let's say that 2 milligrams for whatever disease we're treating, 2 milligrams is really good. It really works. We would expect to see the people, the 90% that actually took the 2 milligram medication every day, to get much better than the people randomly assigned to the 2 milligram group that say the 10% that did not take it. If they're not taking a medication that really works, they're not going to get better. If they are taking a medication that really works, it makes sense that they would get better, right? Okay. But the really interesting thing that happens from a psychological standpoint is even people randomly assigned to a placebo control, the people who comply and do whatever they're supposed to be doing, they get better compared to the people that aren't complying and not doing what they're supposed to be doing. And that's called a compliance or an adherence effect. But keep in mind, this is like placebo times placebo, right? Because they're in the placebo group. But these people that are complying and taking that medication every day, they're doing so because they think it's going to be helpful to them. These people who are not doing it on a daily basis, probably because they don't trust it. They don't think it's going to be helpful to them. So just the belief that something could be helpful to you is a definition of placebo. And so in science, placebo is oftentimes treated as if it is a nuisance, okay? But in the field of healthcare, placebo is something that we want to use. We want to deliver placebo the best that we can. And one of the ways that we do that, whether you're an occupational therapist, clinical psychologist, medical doctor, is being enthused about the treatment that you are giving somebody, okay? It would be the nurse out there vaccinating people saying, thank you for coming in to be vaccinated. This is going to prevent you from getting infected. As opposed to, here's your vaccine, boop, see ya. See you in 3 weeks or see you in a month, right? That enthusiasm and that confidence about what you are giving to people is placebo on top of the treatment. Any questions about that? Okay. Epidemiological designs are when we look at associations. So it was kind of like what Semmelweis did when he was collecting that data in the hospital. And I'll give you an example here. I've done a couple of studies with some other faculty members. Let's talk about rural teens and dating violence. We studied in local high schools. This is Ashland Allegheny High School. We took the Youth Risk Behavior Surveillance Survey, the YRBS, the CDC develops this survey, and it was given to these rural kids in these two high schools. And we asked these teenagers if they had been a victim of physical dating violence and if they had been a victim of rape, okay? And then we looked at those events being victim of dating violence and victim of rape, and we looked at associative risks. And we compared those risks. I'll show you these risks here in a second. We compared those with dating violence to those who did not have dating violence, those who had been raped compared to those who had not been raped. And we looked at mental health data. And the statistic that we calculated for these individuals was called a relative risk ratio. So these are the female teenagers. And I just want to give you an example of, so a female teenager who said she'd been a victim of dating violence versus females who had not been victims of dating violence had 4.4 times higher also reporting substance use. Okay. This one up here, just as an example, would be both would be if they both said, yes, I've been a victim of physical dating violence and I've been a victim of rape. So both of those events occurred in those classified as both. They had almost 9 times higher substance use compared to these teenagers, no dating violence, no rape. Does that make some sense? And then an example here, those who'd been victims of both the dating violence and the rape, almost 6 times higher the depression compared to those who had not, no dating violence, no rape. Okay. And look at all of these different risk factors that were associated with this interpersonal violence. We've got suicidal ideation, we've got unsafe sex, risky sex, number of partners. And then down here at the bottom, I want to point this out. The women with dating violence had lower grades compared to the women without dating violence. And the women who had been raped had lower grades in high school than the women who had not been raped. And what we're talking about here, when you actually looked at their grade point averages, we're talking about the women who'd been victims of interpersonal violence had a C average. The women without being a victim of interpersonal violence had an A average in high school. That's really important, you all, because that A average is going to translate into her more likely going to community college, more likely going to a 4-year college. That is likely going to be predicting her socioeconomic status and her income throughout her lifespan. And there's a really interesting, one of my friends who does some rural research even found the best predictor in a rural area when a child has a disability, the best predictor of that child's disability getting diagnosed through a pediatrician's office is mom has a college education. It doesn't matter if there's a dad involved. If dad has a college education, that doesn't predict. But mom with a college education, likely because she's educated and she's like, there's something concerning about my child. I'm going to go to the pediatrician and go, you know, could this be ADHD? Could this be autism? There's something I'm worried about with my kid. So I'm extrapolating here, but the reason why this data impacted me so much is that it saddens me very much. These teenagers, when they are a victim of interpersonal violence, for a lot of these women, young women, it changes the trajectory of their entire lives, if that makes some sense. You got it? Because those A grades versus those C grades, that's important. Okay. Okay. I know we're getting close to time. Another example here, many of you have had Dr. Mary Ballard. Some of you may have had JP Jameson. This was a study that we ran together. And we did the same kind of thing, but instead what we looked at in these rural teenagers was if they identified as LGBT, we didn't have Q on the questionnaire, so there was no Q involved, but LGBT versus the students that identified as being heterosexual, straight, as well as cisgendered. So LGBTQ versus non-LGBT kids. And again, we ran relative risk ratios. We found these LGBT teens 5 times the risk of suicide, 1.25 times higher being bullied, almost twice as much school violence directed at them, 1.5 times more drug use, and 1.26 times risky sexual behavior. What this told us, which was intuitive to me, but this is what the data suggests, it is hard to be LGBT in a rural area, okay? particularly in a rural area that has no LGBT support in the school system. Okay. So again, not really surprising data. Okay. We will pick back up in our next class on this, but I'll go through this one more slide and then we will call it a day. Integrative medicine, which is where we've got the traditional medicine, we've got the nutrition, the dietitians, we've got the physical therapy, we've got the psychologists, we've got all of these people working together, follows what is called a biopsychosocial spiritual model, meaning it treats the person or people as whole people, okay? And so we can go all the way as low down to the biology, the chemistry, and the physics, and study scientifically. The psychology is their emotions, cognition, behavior. Socially, their relationships, their institutions. And then up at a spiritual level, their values, their beliefs, their sense of meaning. It could be a connection. This could be traditional religion and a belief in God and the connection with God. It could be a connection with nature. It could be a sense of connection to human nature, like we're all in this together type of thing. But biopsychosocial spiritual, and we're going to be thinking about women in healthcare this semester as complete human beings. Okay, any questions there? Okay. Please do watch, if you haven't seen it already, the New Medicine documentary is up on As You Learn. So kind of your homework, if you haven't seen that yet. And you're going to see that there's a lot of overlap between the doctors and the cases in the New Medicine and what we've talked about in lecture. I will keep lecturing on this kind of stuff next Tuesday. Plan is to finish the introductory lecture on Tuesday and start stress and stress management. If I find us getting a little bit behind, I may record some lectures and have you all watch those outside of the class time, watch them asynchronously. I can peek at the chat now. Let's see what's in the chat. Yes, okay, I see what you've got in there. Any questions before we stop today? Thank you for those of you who have participated. That is very helpful to have some interaction going on. I hope you have a great weekend. Saturday looks like the weather's going to be beautiful, at least up here in Boone. So y'all take care and I will see you next week. Bye.